Emeran, it's a great to chat to you. I've been a long-time follower and reader of your newsletter as well. So it's a pleasure to have you here.
Same here. Thanks for having me on the show.
People more and more are talking about gut health, and we're understanding that gut health has ramifications beyond just the gut, in the brain, in the skin, mood, cognition. One of the things which is an underrated factor in gut health and how it influences our gut is stress. Stress is not just psychological, but it's proven to be a physiological influence on our body, from constipation to diarrhea and various other disorders. How big of a role is stress on gut health?
Well, stress, the way I'd like to define it, is any real or anticipated perturbation of the balance or the homeostasis that your body is in. So this could be anything. This could be a unhealthy diet. This could be psychological stress. This could be physical stress like heat or cold. The body is a phenomenal homeostatic machine, has multiple, probably hundreds of thousands of mechanisms, biological mechanisms to compensate for any disturbance, no matter if it's actually happening or if you anticipate this to happen in the future. So there's a lot of expectation stress, particularly negative expectations about food, what it's going to do. And that, so some people sit down for their meal and are totally stressed out because their brain constantly makes this prediction, something may be wrong, something is bad for my health. And so I would say we have a pretty universal definition of stress. Psychological is just one of them. It's not the only one. And I sort of like to think about this combination of the dietary stress, which is basically stress for our gut system, and the psychological stress. Both of them happen at the same time at the moment in our modern society.
Now, in terms of how the brain influences the gut, we know that for many people with chronic pain, the root cause may be, in the brain, in the nervous system, resulting in, abnormal pain perception. What is the link between chronic pain and the gut, and the crosstalk between the gut and brain?
I always emphasize that anything that happens in the brain will have a mirror image and at the gut level, even though most people don't feel that. People with IBS, for example, they do with irritable bowel syndrome, but you almost have to sort of compare it to your facial expressions, or I would say expressions of your emotions. But the same thing happens at the gut level. I would say to a lesser degree with the other organs, with the heart, it's definitely another one. But because our communications through the autonomic nervous system and the sensory nerves with the gut are so much closer than with the other organs, the expression at the gut level is greater of the emotional and the stress level. So anybody who has chronic pain will have I would say, a chronic tone on the gut that will alter its function. You won't notice that right away, but I'm gonna give you one example. I just recently broke my hip and had a hip replacement, and I had significant initially pain, but then significant discomfort for a while. It certainly affects everything in your body. If you're a sensitive individual, it's not just the pain; it affects everything. Your sleep in it. What most people don't experience is that it affects also the gut. And however the gut is affected, it will send feedback signals back to the brain, to centers within the brain, certainly into the sensory system, but also into other, the salient system, the central autonomic nervous system, that will be a response to what's happening in the gut. So it's always this circular motion. Because of this, I don't like the term brain-gut axis, because that implies it's sort of a simple linear relationship. It's a system that always goes, in both directions and tries to compute the optimal outcome. I think we always have to remember our bodies and brains, including the brain-gut communication, are extremely sophisticated systems, have developed over millions of years, and always try to compute the best outcome for us in this situation. The reason that's not quite working out right now is because all the things that are happening around us, our bodies have not really evolved to this new situation perfectly.
And extrapolating that crosstalk between the gut and brain, you mentioned it's that ecosystem. And within that complex ecosystem, the gut microbes are producing precursors to neurotransmitters and other chemicals which have a direct impact on the brain. How quickly can the gut microbes influence the brain and affect the brain? Are we talking in a matter of hours to days, or is it a longer habitual relationship over weeks and months and years?
I would say the best answer is both. Both these situations happen. Let me start with the long-term influence. So, we talk about neurodegenerative diseases, cognitive decline, Alzheimer's disease, Parkinson's. These are kind of long-term influences of gut signals, of gut microbial signals. Right now, we think mainly about inflammatory signals to the brain, engaging the brain's immune system, and that takes years or decades of so an unhealthy diet starting in young adulthood may manifest 30 years later in early cognitive decline. But then there's also rapid responses, and those responses are most likely mediated by the sensory aspect of the vagus nerve. So the microbes produce a lot of molecules, neuroactive and other signals that interact with these sensors, these nerve sensors that we have in the gut, that then signal this through the vagus nerve to the brain. Also think about this, it's not like the microbe directly talking to the vagus nerve. There's cells in the gut that are the intermediate. So they are like the hormone containing cells. They have receptors for microbial, like short chain fatty acids or secondary bile acids, which then make the cell release a neurotransmitter that acts on the vagus nerve, and that signal goes up to the brain. So we know actually quite a bit about both the long-term and the short-term signaling from the microbes to the brain.
And in your work, when you're looking at that neurobiology of stress, when it comes to the gut and brain, how equal is that relationship? I mean, which one is the primary influencer on the other? Because clearly the brain in both acute and long-term settings, as you've just outlined, can have ramifications on the gut. And you've also said that the gut is a mirror of the brain. And as you just mentioned, the hormones, the gut cells can influence the brain. So which one is the bigger of the two, the bigger brother, if you will?
Yeah, that's a good question. I'm not sure if I can answer this 100% with 100% certainty. I started my research really on the effects of the brain on the gut. So, and spent a lot of time in chronic pain, in the chronic pain field. So a lot of it was always top down. And even if you take a field like chronic pain, there's a group of scientists who think it's all in the periphery, and others say it's all in the brain. And probably the answer is it's this interaction of those two systems. I think that the sophistication of our big brain probably surpasses the sophistication of the gut. But I wouldn't say this 100%. I think we're still learning, and it may rather be that they're equals, but with different emphasis. What they respond to, and like the psychological stress. Clearly, I mean, the brain is the main driver. To chronic pain, both the periphery, the gut, and the brain could be the main drivers. For dietary stress, it's definitely the gut where it originates. So I think it also depends on the kind of stress that we're talking about.
One thing I'm interested to unpack is that you've mentioned before that even the expectation of stress can impact gut health. And I see this as analogous to maybe you see someone yawn and you might feel the urge to yawn yourself, some sort of mirror neuron activation. Is that a similar function in that expectation of, abdominal pain could then impact, your gut health? How exactly does that work?
Yeah, I sort of like this image of, or this term, that the brain is the most sophisticated prediction machine in the universe. And when you think about it, just like any artificial intelligence, I mean, the brain constantly makes predictions on different time scales, on a millisecond scale. Like you go through life, and the brain is constantly observing, collecting data, and making predictions. Like when you eat something and you think this may be hot, it makes a prediction it's too hot, you have to slow down. But then there's also on a longer term basis, like for example, if you sit inside your living room and somebody talks about the weather, how the weather is going to be this afternoon, we might then make the brain then makes a long-term prediction. Okay, if I go out this afternoon, I have to dress in a specific way. So I would say this expectation that so many people have. So there's the expectation or the food-related fear of gluten. Some people have like a whole list of things that they are afraid of when they sit down when they go to a restaurant. So they don't even give the food itself a chance to try it out because all their predictions are so negative that it will keep you from eating those things. And then when you actually eat them, you will have a negative reaction because the brain system is set in a way that it reacts as if this food is bad. I like to apply this particularly to the non-celiac gluten sensitivity, where millions of people have eliminated gluten from their diet because they're afraid, and there were best-selling books on this. For the majority of these situations, we don't have any scientific explanations why this would be bad for you. And there have been double-blinded tests of this, and people did not have a reaction, didn't know when they were eating the gluten-containing food. So I think the images that we carry in our brain about our world, including the food that we eat, or have a very strong influence and often can override the actual reality.
Do you think that now that we're understanding that conditions like irritable bowel syndrome are brain gut disorders where, maybe one has to focus on both components for management of the condition, there is some link potentially between some childhood traumatic events and then the development of adult gut disorders, and potentially in the treatment paradigm for a lot of these brain gut disorders, we're missing a piece of the puzzle by not focusing on the psychological aspects?
Yeah, certainly. It's been interesting for me because my group has sort of written about this for the last 40 years that IBS and other related so-called functional diseases are brain gut disorders, and this was not accepted for a long time, neither by patients nor by my colleagues or the field. And fortunately, this has changed now. There's definitely a very strong influence or a very important role of these early life experiences. And that is, the first 1,000 days of life, starting, you could almost say starting with conception, that there's it's a programming phase, both for the gut microbes, for the gut itself, and for the gut-associated immune system. It's programmed for a future or for a reality that mirrors what's happening in those 1,000 days. So nature has sort of come up with this. If you experience something early in your life, that's most likely the most relevant influence for the rest of your life. And this may have been true in the past, our ancestors, but it's not really working that well anymore because just because you had some kind of early adversity, and that could be a whole range of things. It could be anything from an unhappy, discordant marriage with your parents to a divorce to a chronic illness of your mother. Any of these fall into this category. And that doesn't necessarily mean that the rest of your life is the same way. So I think what we see today is actually very similar to, there's many examples of this, that what nature has come up with in programming or anticipating the future and optimizing our homeostatic system doesn't really work that well anymore because we're not confronted with roaring tigers or other life-threatening animals. So people have called this mismatch of our gut microbiome with the gut and our environment with the gut microbiome. So we've sort of gone out of balance. It's this word in the Hopi language, Koyani, Squatsi, world out of balance, that sort of characterizes this. And I think we are really experiencing this more and more, because many of the things that are happening today are even more. Nature could never have had anticipated those things happening today.
Yeah, I'm really fascinated also, particularly about this, increasing understanding about how potentially our gut microbes could influence and, to some degree, this might sound like a exaggerated word, but control our behavior to some extent. I think if you're organized and conscientious, people who meet those criteria tend to have more butyrate producing bacteria. And I think there is some associative data suggesting that outgoing toddlers have more diverse microbes, especially boys. Clearly, this is all associative data. We need more studies to prove some causality between those two events. But to what extent do you think the microbes can influence our behavior and our personalities?
Well, I mean, one extreme and very good example is, so if you ingest a pathogen like enterotoxigenic E. coli, that will dramatically change your behavior, like almost instantly. You will stop eating, you feel bad, you will withdraw. So pathogens are very good in doing this, and there's many examples of parasites going to very specific areas of the brain, changing dopamine release. I mean, it's kind of amazing the knowledge that some of these microorganisms have in terms of influencing human behavior. If what we have observed and seen from many studies with the microbiome, and this has been particularly with germ-free animals or fecal microbial transplants in mice, that it changes emotion-like behavior in these animals, I think that's harder to reproduce in humans, mainly because in these mice, you can control everything from the genetic background, the food, the temperature. So they are basically, you can eliminate any other factors that influence behavior, except for this manipulation of the gut microbes. So you see a measurable effect. In humans, you can never do this because there's hundreds of factors that influence our behavior, from past experiences to any environmental stimulus. And so maybe the variance that the microbes contribute to our behavior is maybe 5% max, maybe less than that. And all the other factors, play equally important roles. So I would say our behavior is influenced by the integration of all these different influences. And we don't have this in the mouse, in the lab mouse. So I would say they do occur in humans. They're very strong with pathogens, but they're less detectable or more difficult to detect for our microbiome in humans.
Other things which I think are very interesting is how our microbes can influence others around us. For example, I believe living with others or simply sharing hugs, sharing meals, sharing, kisses and bodily fluids can make your microbes more similar to other people around you. And there are some microbes which can even influence the production of oxytocin, the hormone behind connection and bonding. So I wonder if the sort of the community of bacteria that we share with each other are almost as important, if not more important, than just our own. The sort of microbes that we inherit from our parents or transfer and receive from friends, family members, pets, even, and how they might influence not just disease risk, but our mood and also personality to some degree.
I think they definitely this plays a significant role, and there's this whole story about, we always talk about the Mediterranean diet, but it's really the Mediterranean lifestyle, and a key
Mm.
component of that lifestyle. And it doesn't just happen in Mediterranean countries, it actually happens in the majority of countries in the world. Social interactions are a very important part of influencing our health, our behavior, the way we feel. And some of this is obviously psychological, but a lot of it is certainly mediated through the exchange of bacteria. So within a family with more similar microbiomes than with somebody else who is outside our family. You mentioned the pets play a big role, and that plays a particularly important role early in life. still this programming phase. So kids that are born by C-section, obviously the first year or so, they have a very different microbiome, but then as they grow up in the family, the babies exchange microbes with their moms, contact with the breast milk, with the pets that are in this household. So by the time they're 3 years old, it's not just this early programming to the microbes that are in the birth canal, going through the birth canal, but it's all these environmental things in the family. As I said, I mean, there's definitely time windows where this influence is greater than it's in others. So again, the first 1,000 days or 3 years of life are probably the most important ones where these influences play a big role. I don't know if you're ever going to get studied. It's very difficult to do these studies in humans because, I mean, how do you control all the other factors? Somebody growing up with, to show that somebody who grows up with pets is more optimistic. I mean, there's so many other factors that would influence this optimism from genes too. But I would say, like everything else in biology, it's systems biology. It's never one factor. It's multiple factors interacting, and somehow complex organisms compute from hundreds or thousands of these influences the outcome. And the microbes are definitely one influence in this computation.
And just bringing it back to that conversation about chronic pain and the link with gut, a lot of people who suffer from these functional disorders like irritable bowel syndrome or SIBO or any number of, functional gut disorders, they also tend to suffer with a degree of chronic pain as well. It seems for many of these people that the typical medical institution lets them down, maybe because of lack of understanding of what you've described or lack of available treatment options. What can people do in these cases when they do have this chronic pain? What are some of those actionables that they can employ to target that gut-brain connection and that psychological aspect that someone could just do themselves at home, but also medical treatments they could explore?
Yeah, I mean, I always say it starts with the becoming aware of it, the acceptance. I think one of the most important things for a physician is to accept the model that the patient brings to you and the experiences. With so long, and still, I think a lot of doctors basically, this can't be like you imagine this. You have a gut issue. Like all these other aches and pains are psychological, or you're hysterical. And I mean, some people early in my career, some prominent people called during their lectures brain gut disorders the disorders of neurotic housewives. So there's a lot of this prejudice that's still and not acceptance. So the first thing is acceptance of the symptom complex that patients present to you. It requires a detailed history taking because they come to you, for example, as a gastroenterologist, not with their migraine or with their low back pain or with their vaginal pain. They talk to you primarily about their gut health. But if you take the detailed history, you'll see that all these other things are present. And some people, see 5 different specialists at the same time. That's not a good model because all these specialists have their own theories. Most of them are not scientifically proven. Fortunately, I would say the field is gradually, both in terms of the science, but also in some integrated physicians. There's a whole group of physicians called, functional medicine approaches. They realize this is all part of the puzzle. This is not a monosymptomatic disease if you have something in your gut. We've done a recent study where we found that, so first of all, these other symptoms or comorbidities are more common in female patients. And secondly, they're more common in patients with an increased stress responsiveness. So their stress system is triggered faster by smaller stressful stimuli than in others. And you can identify this group either based on questionnaires, but we also found they have a different microbiome. So the combination of being female and having increased stress responsiveness will make it more likely that you have multiple of these diseases. So then the question is, what do you do? I think you have to work with a behaviorally oriented psychiatrist, not psychiatrist, psychologist. Only in the most severe cases, I would get a psychiatrist, specialized psychiatrist involved with medication. But behavioral approaches to these disorders are probably right now the most effective ones, starting with simple breathing techniques if somebody has mild symptoms, to cognitive behavioral therapy, to gut directed hypnosis. So there's multiple approaches, and there's now specialized psychologists who are pretty good in this, and the studies on it. It's still, if somebody has these multiple symptoms, it's obviously harder to treat that person and make that person symptom free than somebody who just has bloating, or slow or too fast gut transit. So I would say we have come a long way with this. Fortunately, I think the science is now embracing this, that multiple symptoms are the rule. It's not an exception. I even don't like comorbidity. I think it's part of the disease. It's a dysregulation of homeostasis and sensors in the brain that bias the system towards a greater responsiveness to many sensory inputs that the brain gets from the body. So hypersensitivity, it's another one. We've done a lot of early studies on gut hypersensitivity, did these archaic studies with balloon distension in the rectum, and found that patients with IBS are more sensitive to these stimuli. But in the meantime, we have a concept that these interoceptive stimuli that the brain constantly gets to monitor the homeostasis in your body, if the sensors are altered in a way that they're more sensitive, then you experience things that somebody may not feel, or feel very mildly, as pain. So central pain amplification or sensory amplification, I think, is a big part of this.
What is your take on the dietary manipulation of the gut to improve brain health? Because when someone starts to increase their fiber intake, they may not feel any effect day one, day two, or even week one, maybe some improvements in bloating or bowel regularity. But over several weeks, there may be a change in, sustained change in gut microbiota composition, more short chain fatty acid production. And then you might start to get some of those deeper benefits over weeks and months with skin health, immune health, potentially even brain health as well. Is that one long-term strategy, the higher fiber and prebiotics, but also things like adding in fermented foods? And, I think one of the very earliest studies in the Royal Bethlehem Hospital, again, pretty anecdotal, but when, a doctor prescribed kefir to depressed patients, there was some anecdotal response of improvement of depressive symptoms. So, extrapolating that, we know that, some fermented food intake is beneficial for most people. So those dietary manipulations, how strong do you think they could be, and how big a role do you think they could have long term?
Diet is one of the most effective strategies. I would not recommend diet alone to my patients. I actually never do. I always tackle the brain gut system at both levels. So we know, the Mediterranean diet has gotten a lot of good press and a lot of attention. And, I kind of love this idea that the Mediterranean basis for thousands of years has been able to experiment with different diets of all the countries around it. And they've come up with something that is not just tasty, with slight modification in each of the countries, but that's also the most beneficial. So we have had a natural experiment over 2,000 years minimum to come up with the optimal diet. That doesn't mean that other parts of the world have a similar kind of, I would almost say ancestral diet. So in Asia, we know in Okinawa, in Japan, even in China, before the onslaught of Western meat overconsumption and ultra processed foods, all these countries or indigenous people on the Amazon or in Africa, if you look at it, they all had a kind of a similar diet, interestingly. And it was always emphasized on, about plus minus 70% plant-based food. Now, why plant-based food? As you mentioned, there's the fiber content, something that's often forgotten, the polyphenol content. So these are also these large molecules contained in fruits and vegetables that are digested by the microbes and then strengthen both the microbial system, but also the breakdown products go to the brain and to the body and have beneficial effects. And the third arm, so we have the fiber, the polyphenols, and the fermented foods. And the fermented foods are not, the yogurts, the highly processed or ultra processed yogurts that people, have become in vogue in the US. Humans have fermented food for thousands of years. So enough time to have our genes adapt to this food. And so our gut is adapted to get a significant portion of our diet in the form of fermented foods. So three major components, I think, that underlie the health benefits of these diets in different parts of the world at different stages of history. Right now, I think most of the studies exist on the Mediterranean diet, and that's also has some question marks because the original Mediterranean diet, as described, was from the island of Crete, of very poor people that, because of economic reasons, had a very limited diet, lots of pasta. What we see today in Italian restaurants is not the Mediterranean diet that we would recommend. I think it's better to say 75% plant-based, the rest coming ideally from poultry and fish, and the avoidance of sugar. I mean, those are the kind of the criteria that I would say today are the most supported by science.
Over the years, and certainly over the last few decades, there's been a rising incidence in gut problems. I mean, first irritable bowel syndrome, but also we've heard more and more over the last few years about SIBO, small intestinal bacterial overgrowth. This seems to be coming up more and more frequently, and there's a lot of people with unexplained gut symptoms or unexplained chronic bloating who either have self-diagnosed with SIBO or they are getting that you see a higher frequency of this SIBO diagnosis. Do you think that it's a very common condition that we have traditionally underdiagnosed and now we are beginning to diagnose it more, or the other way around where it's being used as a catch-all diagnosis for things that we haven't tested for enough or identified a proper diagnosis, so SIBO is used in lieu of a actual diagnosis?
I prefer your second interpretation. I think it's being used to describe symptoms that patients have always talked about, but it wasn't something that you would bring up at a dinner conversation or at a party, that you're bloated and have increased gas. Nobody would talk about that. But now you can talk about SIBO. I have SIBO. I take antibiotics for SIBO. It's been made acceptable. But if you look at it, there was just a recent review article by some of the leading voices in gastroenterology, highly critical of the concept, not just the concept, but also the way it's being diagnosed. These breath tests are not reliable. There's many people are totally asymptomatic that have positive breath tests and vice versa. These breath tests are influenced by gut transit, for example, not just by the number of bacteria. I mean, there are normally bacteria, microbes in the small intestine, all the way up to the duodenum, in smaller and smaller concentrations. Like when I was going to medical school, SIBO was actually a very rare diagnosis, and it was made in patients who had severe compromised intestinal motility, like scleroderma, for example, where the gut doesn't move. And so the food sits there and leads to this overgrowth of bacteria and throughout the small intestine. That was rare. At the time, a test to do this was put a tube down and aspirate fluid from the small intestine. Very difficult to do. Nobody does that anymore. And then culture the material. But the breath tests, that's step number one, problem number one. They're not reliable. They're not specific. Secondly, the symptoms are very nonspecific. very noticeable, gastroenterologists and scientists have done studies on bloating, for example, and dispelled some of the myths around bloating. It's not necessarily increased gas production. It's increased sensitivity. When our microbes break down complex carbohydrates in the colon or in the end of the small intestine, that produces gas as a normal. So it's particularly, legumes like beans and peas. A healthy person may have transient, very brief lasting discomfort of feeling, God, I've eaten too many beans or too many peas, but it's not a disease. But if you have a hypersensitive gut, like IBS patients have, or many patients with functional GI disorders have, that is very uncomfortable. So you increase the air pressure in the gut, and you have a hypersensitive gut, and it will cause a tremendous amount of symptoms. So I think this is the much more likely explanation. And unfortunately, the SIBO lobby, I would say, and there's a lobby behind it because the lobby wants to sell you the antibiotic, the rifaximin. So a whole industry has developed both the testing that hospitals make money on and the pharmaceutical industry that wants to sell even repeated doses of this rifaximin. That's the worst part because, I don't care if the hospitals charge you for it, but to be put on an antibiotic in this day and age where we know that's the worst thing can do to the health of your microbiome is just not, I would say, non-ethical.
Yeah, I mean, this may be controversial, but I feel one of the biggest failings that we have as doctors and the medical institution is that we constantly think horses when we hear hooves, right? Sometimes you may need to think of zebras or another animal that has hooves. So we're boxed into these categories where we associate a condition with a
Yeah.
symptom. So traditionally, we've done this with women's health where you only assume it's a gynecological disorder if someone's got, vaginal discharge or pelvic pain or abnormal periods, you think it could be this. But as we know, with conditions like endometriosis, you could have pneumothoraces, you could have small bowel obstruction or bloating, which are not typically gynecological symptoms. They can
Yeah.
present extra uterine. They can present systemically. And similar with a lot of gut conditions, they can present outside the gut. And one anecdote which is stuck in my mind from my very early years as a doctor and kind of guides me to this day and has led me to this way of thinking and conclusion. There's a patient I saw in a GI clinic years ago, and this person had seen a lot of private doctors, his primary physician, GP, and a couple of other doctors in clinic, in the dermatological clinic, because they'd actually presented with a skin lesion first and foremost, and other GI symptoms as well. And they were just shuttled across different specialties. They came to the GI clinic, and it was quite clearly, with the history and with the presentation, dermatitis herpetiformis, and with the
Mm.
symptoms matched with what sounded like celiac disease. So in the end, on hindsight, it may have been a simple connection, but the presenting complaint was a skin condition. So if the patient tells you, I've got this skin problem, and you don't ask them a full history about any of their GI symptoms, which no one had up to that point because the patient themselves volunteered the skin thing, nothing else, you would probably miss the condition and you'd be focused on the red herring, which is the dermatitis herpetiformis. So this really has me thinking, how many times are we underdiagnosing, misdiagnosing, or overdiagnosing things because we are waylaid by the wrong symptom and we don't think holistically about the brain and the gut and the skin and the gut and the uterus and gut and vagina and so many other things. And are we really missing a trick here and, leaving a lot of patients, in a wrong position?
Yeah, this is really, like your story and what you just talked about is key, I think. And unfortunately, our medical training does not prepare doctors for that. It's still very reductionistic. And the reductionistic education and approach works really well for some acute things. If you break your leg, wonderful. If you have a brain tumor, there's so many phenomenal examples where this works well. it doesn't work for our chronic diseases that we're dealing with. I've always been interested in the interconnection. This term interconnected for me was always something that I'd love to apply to my medical patients and treatments. But for example, this, as you said, the interconnectedness of all the different organs, particularly the skin with the gut, and the gut with the heart and with the brain. It's so obvious now. And then, people talk about, again, this is a reductionistic remnant, to talk about the gut-skin axis. Well, it's one of the connections. There's not a specific, specialized, simple axis. It's part of this network of connections, how our bodies are designed. And as I said, clinically functional medicine practitioners are taught in this way. In science, I think we're seeing a revolution with this concept of systems biology, which also links multiple factors together in the outcome. I think by using AI more and more, we sort of have a technical version of this, because the AI basically integrates so many different sources that we, as traditionally trained physicians, wouldn't have time to do. It goes through all the literature. And so I think the field is gradually changing, but it will take a while. It will take at least another decade or more before we're fully arrived at this. And the sad thing is, if you have this holistic view of the body and health and disease, it's a lot cheaper. The medicine based on that is a lot cheaper. You don't have to do all these expensive tests, and that the first reaction is to get an MRI, and it's kind of interesting to me. So now, these annual MRIs have become in vogue for wealthy people, that they get their health assessment by this. Yeah, I mean, you will pick up early cancers with that, but it's still focusing on something simple to explain. And coming back to the whole bloating story, before the concept of SIBO, gastroenterologists and physicians they didn't know what to say. They could only say, well, we don't know exactly, maybe you should take, say, methicon to decrease the gas production. And now they can say, oh, it's SIBO. I have something very effective. So this is one of the main reasons it's become so popular, because physicians have jumped on this. They now can explain to the patient what the cause of their so-called cause of their symptoms is.
Yeah, I think the work you're doing to connect all of these different systems is really fascinating. And, I just want to thank you for sharing your expertise and joining me on this podcast. Thank you very much.
Thank you for inviting me. It's been a privilege to be on your show. Thank you.